everyone. Welcome to the first IUCD Canada webinar of 2025. My name is Caroline Cameron. I'm a professor of microbiology at the University of Victoria and president of IUCD Canada. On behalf of the IUCD Canada Executive Board, we thank you for joining us today. For those of you who are new to our organization, IUCD Canada is the Canadian branch of the International Union Against Sexually Transmitted Infections and is part of IUCD North America and one of 5 regions under the umbrella organization of IUCD World. Our membership drive is occurring, and I encourage you to consider joining IUCD Canada. A regular membership is $60 and $30 for a trainee. To make it easy, here is a QR code. The funds we generate through memberships allow us to offer scholarships for early career professionals to attend IUCD-related meetings and to offer webinars like the one we are hosting today. Before we start our webinar, I would like to give a big thanks to Greg Penny, Director of National Programs at the Canadian Public Health Association. Greg is hosting this webinar and provides endless support to our organization. It's my pleasure to introduce our webinar speaker today. Dr. Nikki Pagpai is a professor in the Department of Medicine at McGill University. Nikki is a global health expert specializing in point-of-care diagnostics, digital health, sexual and reproductive health. She has funding from CIHR, NIH, Gates Foundation, and Grand Challenges Canada. She has published widely in leading journals and received many international and national awards for excellence in research, including being a member of the Royal Society of Canada, and she's been honored as a Canadian woman leader in global health by The Economist. And now it's my pleasure to turn the virtual stage over to Nikki, who will talk about multiplex diagnostics for STI HIV. We say complex.
Nikki, you're muted.
Wow, sorry about that. Thank you, Caroline, for giving me this wonderful introduction. I'm deeply honored to be opening the series of seminars for this year, and we hope that you would have a great session and enjoy learning with us. We've also made it a little engaging. So we are going to also have some Slido questions, so which Juhi is going to coordinate for us. So here we go. Just bear with me. I am now putting it on slideshow. Okay, so today we're going to talk about the multiplex technologies, right? And we think that they are very complex, and they are. They have been in evolution for the past decade and a half. I've already been, Caroline has already introduced me, so I'm going to skip over this slide, but my intentionality about talking about point of care was when I started work in point of care, it was driven by this passion of doing something that was better than science. And Bill Figi, who's credited with the eradication of smallpox, said that there's something better than science, that is science with a moral compass, science that contributes to social equity, and science that is in the service of humanity. So this is how I've laid out the learning objectives for today. We are first going to talk about why we should care about diagnostics. What is the investment case here? What's point of care, some general and specific concepts. What is the environment? What is happening in the space outside of point of care diagnostics? How are things changing in the space? Then introduce the concept of multiplexed for HIV and STIs. Talk about different types of multiplex technologies, and do a deep dive, but not a lot because I'd only have 45 minutes. But you're very welcome to ask me questions or email questions to us. Then we'll talk about the evidence, what is out there in terms of implementation, talk about the challenges of and complexities of multiplexing, and then talk about the future of multiplexing. So the question that I have for you all is to really think about, why should we in 2025 care about diagnostics? What is it that diagnostics really helps us achieve? And you could say that it achieves a lot of things, because without diagnostics, you cannot really take that first step towards improving the life of anybody with a condition. So they only get termed a patient when we understand and get the knowledge of their serostatus. And that is the first step towards really guiding the treatment decisions. Diagnostics increasingly also helps improve access to diagnostics in the form of point of care, which I'll make the case, and hopefully you'll be convinced at the end of it all. And if we use the right diagnostics at the right time, in the right populations, we can improve the quality of care. And here I'm talking about the underserved populations who almost are so used to empirical treatments that they don't even think that testing is necessary. If we use the right diagnostics, we can reduce overuse of antibiotics. And as we know, AMR is a big problem now. It's almost the next pandemic. And then we also reduce inappropriate treatments, and that is cost and life saving to the healthcare system. We are talking about decreases in morbidity and mortality. And that can only be accomplished if we use diagnostics at the right place, at the right time, for the right condition, with the right set of people. And in terms of surveillance, as we've seen during COVID, it also enables active and quality surveillance. And that is, people from PHAC can attest to that. And that was very evident in the pandemic response. And so through it all, diagnostics can achieve many things. And all of this is all public health. So there is this question for you, Slido question. So over to you, Juhi.
Sure. So everybody, if you could please just scan our QR code that we have here, and I'll be able to see when you've joined in on the Slido. Yeah.
So how many individuals worldwide, what is your guess, have no access to diagnostics, quality diagnostics?
Okay, I've got some people joining in the Slido, Dr. Pi. So we have 2 people so far. I'll start it as soon as I see we have about 60 people here. So we'll just give them a bit of time to join in.
We'll make you get used to Slido so that you can also be engaged. Otherwise, it's sort of like a bit more fun. Did you get some answers, Juhi?
So I'm just waiting for everyone to join in. I've got maybe about 20 people. So I'll just start
So
with the
what is the
first
answer?
question. We'll
The
start with the
question
first
is,
question.
Yep, go ahead.
Yeah, so the first question, as Dr. Pai asked, got some really speedy fingers here. How many individuals worldwide have no access to diagnostics? A lot of people think that the answer is 70%. We have 12% of people who think it's about 25%, and then about 45% of them think that it's about 50% of individuals worldwide. So Dr. Pai, what is the correct answer?
So that's it. So it is 50%. It's precisely 47%. So half of the world's population has no access to quality diagnostics, and it's a shame. And the Lancet Commission recently highlighted that it recognized diagnostics as an essential component of the medical and health ecosystem. So as we know, through the COVID pandemic, we really realized the value of diagnostics. And there is a huge need. If you read this Lancet Commission, we've posted the link here. There is an imminent need to not just embrace diagnostics, but also to support the implementation of diagnostics, the infrastructure around it. And as we know, we have a last mile problem, not only with the uptake of innovations related to diagnostics, but also to the service delivery of diagnostics to the bottom billion. The investment case in diagnostics is straightforward because the costs, the benefits exceed the costs invested. And the Lancet Commission really highlighted 6 priority conditions, and that included NCDs, diabetes, hypertension, HIV, TB, malaria, Hep B, and syphilis. And these 6 priority conditions can actually prevent 1.1 million deaths. So diagnostics, I hope you are convinced that they're essential for universal health coverage. Countries have to develop their frameworks around it. And one of the things that I found really interesting was the fact that there was mention of corruption in the commission. So there are reports of increased corruption in the healthcare system, especially when it relates to procurement of diagnostics. And I think we've never talked about that, and we need to talk about it so that we can, figure out ways to deal with it smartly with evidence-based data. And today we'll actually make a case to really focus on infrastructural support, physical infrastructure, implementation infrastructure that is important. And it also includes training in an expansion of workforce capacity, because once you invest in training of healthcare professionals, they do a better job of implementing diagnostics. So a part of this whole diagnostics spiel is about point of care technologies. And point of care technologies have been around since the 70s. But the thing about point of care is that they've become really popular in, since COVID-19. I think everybody in the world understands the difference between a rapid test and a lab test. If people in your home who are not in the field of medicine, they understand that, then you know that point of care technologies, they don't necessarily understand point of care because it implies point of clinical care, but they do understand the difference between a rapid test and a lab test. So what is it? What is the point of care? I think, is that a question? Yeah, Julie?
Yeah, we have it. We
I
have it
don't
as a
want to move
question.
to the
So
next
I'm
slide.
just waiting for votes. So we have options. It says provide an efficient diagnostic service, provide high quality diagnostics at a reduced cost. And then we have it is versatile, so it can be used in ideal to non-ideal settings to impact care across global settings. So everybody seems to be getting the answer right, and the answer is all of the above.
Great, thank you. I love the engagement. So the point of care is really to meet the needs of the patient. The point of care is to provide a very efficient diagnostic service. The technologies that are around with point of care, they have evolved and they've moved from simple singleton, single test based technology, single pathogen, single infection to multiple. And the ideal point of care test actually evolved for the ICU patients. And then it evolved to ERs, and then a vast majority of point of care tests, and these are the biomarker based tests that we are talking about, the rapid tests, as we know, they were being used by the labs for a long period of time, and they still are being used by the labs. But then there was this transition in 2015 in 2012, when HIV self-test was approved by the FDA, and 2015 and 2016, when WHO curated guidelines for their implementation and guidance, there was a little bit of a shift, and that led to a lot of market demand and market creation that the STAR initiative and the WHO worked upon, and that has sort of made point of care a household name in the African subcontinent. So they are available in the homes, in the labs under a tree. They're also available in mobile clinics and camps. How do you create an efficient service? So the point about point of care is to create an efficient service around it. That is to think of service delivery. And so we are talking about thinking about connectivity, thinking about systems around it, thinking about introducing portable integrated technologies, not just the simple biomarker, but also platform tests, and thinking about how results will be used to impact clinical care. Because there's no point of diagnosing but not treating. So the point of care is not just to diagnose, but also to treat, and ideally in one patient visit. What is the impact? So the metrics that are used for point of care or impact of point of care have also evolved. And one important metric that is being used is the turnaround time. So we should always figure out if we are providing that rapid test result in a rapid turnaround time, which is the point of conduct to the point of result and interpretation and to the point of declaration of result. And that turnaround time is already is built in, and it is supposed to be lesser, like 15 minutes to 30 minutes to 1 hour to 2 hours, compared to lab-based tests. Because the turnaround time with lab-based tests, if you talk about any settings across the world, is from 1 week to 3 week to 4 week. And what does that lead to? That leads to losses to follow-up. And what do losses of follow-up lead to? Losses of follow-up mean that you never get the patients back into care. So the criteria for point of care has been evolving over time. Dr. Peeling has done a lot of work in this space, and the assured criteria came about: accurate, reliable, sensitive, specific, user-friendly, actionable, and deliverable to those in need. And now we have improved point of care criteria for connected point of care solution, and that's called the reassured criteria. But I still feel that there is a need to improve upon these criteria with the multiplexing tests that are coming out in the market. So years ago, when I started out my research, I came up with this image of point of care, and I realized that these point of care tests can not only be used to engage the communities in their own healthcare and the mobile clinics, but they can be used to expand access to primary care in, like, say, mobile camps and mobile vans and lab under a tree. And when you do that, you can use them as screening and triage solutions. Now, point of care also being used for biosurveillance. Point of care as self-test can also empower you. to know your own serostatus. And if they are used time and time again in settings, um, providers are not naturally trained to diagnose. They are only naturally trained to prescribe. But if point of care tests are easily available and easily implementable and integrated, then it also leads to a behavior change in providers, which can enable the workflow processes around it. And, from diagnostics to treatment action plan, they can be prescribed and created in a rapid turnaround time. There is an interesting and important need to talk about business models and sustainable business models, especially in the context of climate change, especially in the context of innovations, and a lot of innovations that fall into the valley of death, and you need sustainability to sort of bring them out and about and help them impact the diagnostic space. And if you create connected solutions and process innovations around point of care, you're talking about synergistic innovations. There is a huge need to teach diagnostics in medical schools, including point of care. And if you do all of that, the point of care will be a game changer. And that's hope. That's my hope and vision. And so point of care are very portable. They are very pliable, convenient. They can be used in any different space. So the good thing about developers and innovators is that one technology can be used and across the spectrum of use. So the spectrum of use varies from let's start with the hospital to the peripheral labs to the secondary labs to clinic and health outposts to the communities and also to homes. And that determines the success and sustainability of this technology. So with that point of care, like background on point of care, the context and the use case, and the definitions and the criteria, all of those are also evolving, and not just for singleton point of care technologies, but also for multiplexed. And the same thing applies for multiplex. Multiplex can also be one day be used conveniently in the homes, and that's my wish. They are certainly being used in community-based settings. They're used in patient care settings. There are lots of digital tools and AI integrated tools around multiplexing, and hopefully we are also moving towards the tricorder. The next section really talks about the environmental changes. So, we can have a technology, but if the environment around the technology does not support the implementation of that technology, then there is no point talking about technology, and it will not really achieve its destiny. So there were three environmental changes that have happened in recent years. One, around 2020, WHO announced its One Health initiative, where it really said that humans have to live healthily create healthy ecosystems so that animals can also be healthy and live together. We need to think about this interaction of human, animal, and environment. And we also need to think about moving towards a society that is inclusive, equitable, and accessible, so that not only one section of the society gets access to the best diagnostics, but everybody in the society has access, so that we can move towards a healthier society overall across the world. And for that, you need 4 C's: communication, collaboration, coordination, and capacity building. And WHO expanded this concept a little further and involved digital health with it, and came up with the One Digital Health strategy, where technology, as you can see the circle in these concentric circles, the technology ring sort of connects everything. It connects the individual health and well-being. It connects that with the population and society, and all of that is nested within the ecosystem, but technology is the great enabler. It also connects, as we realized during COVID, that there was a huge need, and in a world of anti-science, there is a huge need for citizens' engagement in science. Citizens have to appreciate the value that good diagnostics brings to their lives, the value of vaccines, the value of treatment, the value of education in all of this, and the value of the environment changing to enable that. And we also need to worry about human and veterinary healthcare, because that impacts, and as we saw during pandemics, that has a direct correlation with the incidence and prevalence of pandemics. And this technology being the enabler really calls for the healthcare industry evolution, where technology and diagnostics sort of go hand in hand. They will help you monitor, screen, diagnose, and detect problems. And that's how digital health emerged as a key component in politics, and G20 countries announced digital health as being one of the great agenda items. And that also led to the World Health Assembly announcing digital health as being one of the important areas of investment. the environmental change too that happened is that and this is around COVID. So prior to COVID, a lot of us were working in digital health, but we were given a very hard time. And I'm not venting here. I'm just amused as to why we had to go through all of that, because now we don't need to make a case about digitization. Although, as I was talking to Juhi in the morning today, I think we need to set guardrails for abuse of digitization. But that being said, Healthcare 4.0 is a term used for digitally transformed healthcare ecosystems. The guidelines are there, the frameworks are there, the diagnostics are available, and these diagnostics really help you to move from, test results that are not being recorded and stored and not being used to help advance patient care, to connected diagnostics where you are focusing on patient-centered care and you're not focusing on, availability of test result and time. And this has been brought about with all of these different diagnostic solutions and digital health solutions. And all of that, people may wonder, what is digital health? So I've listed everything here. All of this, mobile health, medical products, software as a medical device, algorithms, bots, drugs, companion diagnostics, all of that, computing platforms, sensors, connectivity, software, apps, all of this comes under the umbrella of digital health and AI solutions for health. I did allude to the World Health Assembly. So the digital health strategy that countries are working on, and some countries like UK, US, Singapore, are very far advanced, and Estonia as well. They're talking about these integrated strategies that can also be built on strong governance and can be used appropriately. So the strategies have to be equitable, they have to be safe, smart, secure, and reliable, and also sustainable. And they have to be built on these principles, the FAIR principles of transparency, accessibility, scalability, replicability, interoperability, which is the key to setting up these strategies across all ecosystems, and keeping an eye out on the privacy, data privacy, security, and confidentiality. The environmental change 3 that happened was the increase in prevalence and incidence of STBBI and HIV associated co-infections. For the past decade or so, in January, we were so happy that HIV infection has been on a decline. As we know, UNAIDS announced in 2024 that against the 95, 95, 95 targets, we are at 86, 89, and 93, which I think is a very positive statistic. We hope that the recent changes in funding will not disrupt this, but that's just a hope and a prayer. But as we've noticed, there's been an increase in viral infections, and we're talking about non-HIV infections like Hep C, Hep B, HPV, HSV, monkeypox. There's been an increase in CTNG and syphilis since the 2000s. There's been an increase observed here in Canada too. And CDC attributes this to changes in behaviors, changes in the climate, changes in decreases in condom use. Although there's an increase in awareness, people are still not very careful about behaviors, and there's stigma around STIs. There is that hesitancy in seeking testing, and there is a climate of reduced funding for initiatives. So Canada also came up with Canadian National Action Plans. They talked about strategies to control HIV, and PHAC in Canada has been spearheading these initiatives brilliantly. And SHASTRAC at the CIHR drafted plans to increase the HIV STBBI funding initiatives. So these, we think that are germane to us understanding where and how multiplex sort of fits in. So now I'm going to talk about the concept of multiplex diagnostics and the types of multiplex technologies that are out there, different types, what's the evidence on accuracy and other outcomes, impact outcomes, before I move on to the complexities. So in this climate, if I were to look into the crystal ball, I would say that there are 7 technologies that are poised to really reshape diagnostics. And those are multiplex technologies, with and without machine learning, NGS, next generation sequencing, omics-based technologies that will inform and really accelerate precision medicine, CRISPR-based technologies that can fit into both precision medicine and precision public health, AI, ML integrated technologies that are available and useful for multiplexing, for wearables, for all the multimodal solutions that we have out there, including apps and platforms and chatbots. Then self-testing and self-sampling technologies that are also integrating multiplexing within them. And something that is to come and is being developed by physicists all over the world is quantum technologies. A lot of investment is happening in this space. And once those technologies come in, they will be these quantum chips will be very smart and they will sort of give you rapid results. And so all of this will happen at a faster scale and a pace that I don't think we can actually fathom today. So we'll take a break and we'll ask you a question. So what is multiplexing and what are the two popular multiplexed assays or platforms? Give us two examples. So I'll turn over to Juhi.
Yeah, so the first question is up. So everybody, what is multiplexing? What do you think multiplexing is? So our options are testing one disease at a time, using multiple samples to confirm a result, or detecting multiple analytes or pathogens using a small sample of blood or body fluids. And the last option is retesting a patient after treatment. So I think everyone here understands what multiplexing is, chose the correct answer, which is detecting multiple analytes or pathogens using a small sample of blood or body fluids. We'll move on to the next question. So two popular multiplex tests/assays or platforms. So we have a few options here. Option A, RNA, DNA-based molecular platforms such as Aniplex or Cepheid. And we have option B, rapid antigen testing for COVID-19. And option C, multiplex rapid flow through assays such as ChemBio or Multiplo, or last answer, which is MRI imaging. So I think everybody understands correctly, and they've chosen as well as the multiplexed rapid flow through assays.
Fantastic. So I think I can probably wrap up the presentation. Okay, I'm very happy that you have a deep understanding and you want to learn more. So multiplexing, the concept certainly alludes to detecting multiple analytes, and that they could be anything with a small sample of blood, and that the sample is not necessarily blood. It could be serum, it could be plasma, it could be any body fluid. But the idea is to detect multiple analytes. And multiple pathogens can also be screened. And so we're talking about with ideally a small sample of blood. So it's both analytes and pathogens. And analytes includes, proteins and biomarkers and everything in between. The concept of multiplexing really appeared in the 1980s, believe it or not. And so it's like I was just reflecting on it yesterday. It's like almost 50 years now. That's how long it takes. And it evolved in 1990s into the PCR technologies. Then in 2000, we were talking about these biomarker and platform-based technologies that were becoming really popular, but they hadn't arrived yet. In 2010, I think they were ready for a lot of evaluation in field settings. And post 2010 and 2020, between 2010 and 2020, we saw a rapid uptick in field evaluations, and in 2020, sequencing really had its day with NGS sequencing platforms being adopted by different governments all over the world. And now we are talking about multiplexing as if it's like, it's almost democratized now, which is fantastic. So the types of molecular technologies are the RNA, DNA-based platforms, and then we talk about the flow-through assays that detect biomarkers, and you've given the right answer. There's ChemBio, there's Multiplo, there's INSTI, there are so many of them. And for RNA, DNA-based platforms, there's Cepheid, there's Aniplex, there's a whole variety of these platforms that are being used by labs. So what is the application of these assays and platforms? So basically it's the turnaround time. So between assays and platforms, that is the big difference. Then it's the biomarker that they detect. So the detection of infections with multiplex assays varies from 15 minutes to 1 hour and it's not exactly 1 hour, it's about 30 minutes. But when you implement it in field settings, it takes about an hour, with counseling and with preparation, with patient preparation and all that. The idea is to get the result within one patient visit and to create action plans within the same day. With molecular platforms, again, these are PCR technology based. So you collect the sample, then you run the test. And again, the turnaround time is less than 1 hour. Ideally, because these are confirmatory tests, they sort of subvert that process of sending the samples to the lab. And so ideally one patient visit is enough, and you can test and treat within one single day because you have the confirmatory test result with you. So the benefits of these multiplex applications are rapid clinical decision making, but of course you have to have counseling in place, especially for diseases like, infections like HIV, STIs. You are certainly talking about, with you invest in one platform or in certain technologies, you can save time and money if you are able to manage the patient flow around it. You can certainly use them in detecting infections during pandemics and outbreaks. The PCR-based technologies will be excellent for monitoring, as they were used for surveillance, or they are being used for surveillance. And then we talk about integrated testing, where we are not only screening for, say, COVID-19, so SARS-CoV-2, or we're also screening for TB, and we're screening for respiratory pathogens, and we're also screening for HIV, STBPI panels. So this is called integrated testing, where you are trying to integrate several different vertical programs in field settings. Although that is complex and challenging, but it is not impossible with multiplexing. And that's the good news. But the challenges that we face with multiplexing in field settings, especially as it relates to the platform technologies, are really the cost of the cartridge. The unit cost of cartridge still is high, and I think that it needs to be brought down so that it's almost comparable with the lab tests that are available. And the other challenge that you face is really when you introduce it in field settings, you need to plan those workflow processes in clinics so that you can get the test result in time. You can make sure that enough number of patients come in, get tested, get screened, get counseled, get linked to action plans. You just have to do some back-end planning to be able to execute it and provide this end-to-end solution in a manner that has to be end-to-end for the patient. But it does require infrastructure. So what have we done in our lab? We've looked at multiplexing for a long time now, almost 15 years. And this was the work led by my students and my fellow, Angela Kirilis. She looked at she conducted a systematic review and looked at the accuracy of all the technologies that are out there, biomarker and platform technologies for HIV and STIs. And then after being convinced of the accuracy, we moved on to looking at global evidence on patient-centered and clinical health outcomes. And what is it that we found? We found that the specificity of both these technologies is really high. So when we're talking about high, we're talking about nearing 100%, 99 to 100%, which is fantastic because, it's not just important to know a positive result. It's also important to know that you don't have an infection. So that is the beauty of multiplexing. If the specificity is so high, if you get a negative result, you don't have it, and that's great. The sensitivity is where there is always a challenge, but again, the sensitivity was found to be really higher at 95% for most of the immunochromatographic tests. And immunochromatographic are those that are biomarker-based tests that use antigen antibody biomarkers. And we found that, and this is all my work is without any industry funding, so this is completely free of conflicts of interest. So we found that SD BioLine HIV syphilis test, SD BioLine Duo test stood out. It is an HIV syphilis test. And these immunochromatographic tests, because they are cheaper compared to molecular platforms, they could be recommended, and we recommend them for screening. Now, when it comes to molecular platforms, the sensitivity was very good. And we know this is the reason why most of the labs are using them. And the high-performing machines are Aniplex, AmpliSense, Biorad, Cepheid, Triplex, Versant. So all of these we have, if you read the paper, we've put the reference below. And some of these machines can detect as many as 4 STIs. Is that a good thing or a bad thing? So it's great for the labs, but is that good for the patient is the question that we asked. And Cephid's performance in field setting was greater than 97%, which was also convincing because we were going to use this platform for our studies. So overall, the discussion and the summary of this review was that the diagnostic performance really, and this is sort of this applies to both biomarker tests and platform tests. So it really depends on what pathogen you're trying to screen, what device you're trying to use, what is being captured by the device, whether it's 2 infections or 3 infections. Which populations are you trying to screen? If you're going to use it in a very low prevalence setting, you're not going to get a lot of positives. So you have to be careful about that. So your seropositivity is going to go down, and so will your sensitivity and specificity. And then the type of technology that you want to use. So are you using it for screening or are you using it for confirmation? So you have to be clear about that. And based on your objective, you can decide on which technology you want to use. And this is important when you're doing program planning, like when you're given a lot of money by foundations to run these programs in field settings. And then the evaluation always depends on the reference standard. So it varies by reference standard, but as we noted in our review, that it was fairly consistent. So that being said, we also wanted to move beyond accuracy, and we looked at outcomes, studies that reported on outcomes beyond accuracy. And there were 42 studies that did that. And we focused on patient-centered outcomes and implementation outcomes. We looked at these metrics that are very popular: patient preference, participant tester preference, satisfaction, uptake of testing, positivity, and impact. So the preference was high. Preference for these technologies, 86 to 92% of the participants really preferred multiplexing. It varied from 60 to 97% over conventional labs. The test uptake, obviously, when people were not screened for co-infections, if you offer a multiplex technology that is offering multiplex screening for other pathogens that they don't get screened for, there's always a huge uptake. So it improved by 99% for hepatitis C and for TRIC, and 79% for Hep B, and 42% for HIV. So in most settings, HIV was being offered, and the rest of the pathogens or co-infections were not being offered, which is the case in many global settings. And the impact on linkage to care was varied between 70% to 100%. So 100% happened when they had connected solutions, or when they used it in a setting where everything else was in place, as in the doctors were in place and the treatment was in place. And so it is extremely important to work around the ecosystem of testing. And the turnaround time varied from 14 minutes to 300 minutes, and that's around 5 hours per platform, which means that sometimes in field settings, even though the rapid turnaround time is about an hour, you get the test results in a rapid turnaround time, you actually wait for 4 or 5 samples, because some of these portable machines can do 4 samples at a time. So you wait for 4 samples to come in and you run the machine. So it takes about 4 to 5 hours to get all the results together, and then you can, counsel your patients. But at the end of the day, we found that they address the gaps in the cascade of care, and it appeals to everybody in the ecosystem. So let's talk about other types of multiplexing technology. So this was just biomarker and molecular platforms, but now we're going to get to the other more evolved multiplexing technologies. So sequencing technologies have become really popular. They can detect not only DNA, RNA, but they also can detect mutations and variants. And this is important because when you're talking about an whole genome, when we're talking about sequencing from small samples in a rapid turnaround time, we will actually be able to get so much more information. And that is why WHO now recommends next generation sequencing for surveillance, especially when it comes to resistance mutations. And we need to do that for not just HIV, but also for gonorrhea. And as you know, as you may be aware, you can identify these clusters, not just for pandemics and outbreaks, but also when you are performing studies. You can detect very low abundant variants. You can detect drug resistance mutations for the RT gene. This is extremely powerful technology. And you can also look at metagenomics and study the viral evolution and dynamics in the populations. And that is why the branch of genomics has become so popular. And those of you students in the room who are thinking of where I should go and what kind of diagnostics I should study, I think genomics is the place to be. You can look at genetic patterns. You can look at metabolomics, where you can study metabolites. You can look at metagenomics, which to me is the most important, or is very, very interesting, because you look at the sequences and then you look at it, in a holistic way, and you look at the meta associations, interactions of this omics with the environment, whether it's in the body or whether it's outside the body. And so multi-omics analysis has become really popular because it sort of combines all of these profiles with the metabolic profiles of individuals. And it allows you to move towards precision medicine, where you're not going to just prescribe one medicine for everybody, but you're going to tailor your treatments based on this profile. And you can identify, based on the results that are provided to you, you can identify individuals with a high risk of progression, and then you can prescribe them aggressive treatments. Okay, so from NGS, we move on to microfluidics and nanofluidics. And these are one of my favorites because they are miniaturized versions of multiplex technologies. Microfluidics is one where you can study everything at the microscale. Nanofluidics is one where you can study the flow of fluid at the nanoscale. Both of them have, specific chambers. I'm not a product developer, but it's very fascinating as to how they develop it in field settings. Sorry, in the lab settings, and then use it in field settings. Specimens move through in a specific manner. This is all physics. And in nanotechnology, nanoparticles move through these chambers. For microfluidics, you can think of the RT lamp, you can think of nested PCR, you can think of, fluorescence-based assays, aptamer assays, even CRISPR is part of the microfluidic, like repertoire of assays. And you can talk about, on-chip detection of these antigens and antibodies, and on-chip flow cytometry that is very useful. For nano fluidics, we have platforms that involve these magnetic particles that allow you to actually get a very high sensitive result with very small volume of data of fluid. And so with data and with machine learning, you can actually do a lot of stuff with nanofluidics. So with digital detection, you can not only just enable multiplexing, but also you can do it at a very reasonable cost point. But the reason why these technologies have not taken off is because I think investment has been slow, and they need to really manufacture this at scale with 3D printing. Now, CRISPR, as you know, Jennifer Doudna received the Nobel Award for CRISPR technologies, and you may be aware that it uses it. These are gene editing technologies. Why are they relevant? Because they are the next generation diagnostics for not just HIV, but also for every other co-infection. I mean, once they crack it for HIV, they're going to use it for other co-infections. They not only allow you to detect point mutations and deletions, but they will also help you detect variants, very useful for acute HIV infection. They could be made low cost in the coming years. Currently, I haven't seen very successful evaluations, but I'm aware of many labs around the world who are working in this space, and they are trying to minimize the instrumentation involved and the temperature sensitivity that is involved. Those are the things those are the challenges that they're grappling with. But the thing to ask is, can they be multiplexed? And the answer is yes. They can use different guided RNAs, create and detect, multiple sequences in small samples. So before we get to the last half, which of these technologies could be potentially multiplex technologies? Juhi, over to you.
Yeah, I'm just gonna make the question live. So all the options are actually on your screen right here. So I'll just wait for the answers from you guys. So we've got about 3 votes so far, Dr. Pai. It looks like everyone thinks that pretty much all of these could be used as multiplex technologies. What do you think, Dr. Pai?
Fantastic. That means they're all engaged. Yes, that is the answer. Thank you. Thank you, Joey. Thank you all. Yes, all of them can be used in a multiplexing format. If you want details about multiplex technologies in relation to HIV, please read this paper. We've talked about, there's another paper that's coming out, but it basically talks about, what the future of HIV diagnostics is going to be. It's in press right now, and, I've put in the citation there. But the next section is really going to be about digital and AI with technology. So what is really going to happen when we get all these connected diagnostic solution with multiplexing in field settings? And so basically in 2025, connected diagnostics is everywhere. We started out on this journey of creating process innovations around diagnostics way back, like about a decade ago. And this 8 Smart program with multiplex point of care was basically created for frontline professionals, tested in India. It was funded by Grand Challenges Canada, and later CIHR funded it, and now it's funded by the NIH Potent Group. And the idea is to really educate frontline healthcare professionals, because they are the ones handling all of the testing in field settings and also in community clinic settings. And so you can educate them on managing the data, you can educate them on running diagnostics, helping them link participants to care. If they work as peer counselors, you can also provide high quality counseling services with it. And you can also provide a connected care service with dashboards and make it an even more of a comprehensive strategy. So that being said, this kind of a connected solution plugs the gaps in access, in engagement, in awareness, in communication, in timely screening, and provides timely clinical care. So we've tested this out in different settings. This is an open access solution, and we're ready to share it with you if you want to use it in your settings. And we recently completed an evaluation here in Canada where we tested it out during COVID. We tested the entire package with multiplex point of care biomarker-based tests. We used ChemBio and we used Medmira's Multiplo, and we screened injection drug users in New Brunswick and immigrant and refugee populations in Montreal. And we found that both of these tests worked well. Of course, there was variability in sensitivity. ChemBio comes with a reader, so it was easy to sort of interpret it in field settings and get a higher accuracy, and that sort of eliminated subjectivity. But that being said, both the technology and the solution worked well and impacted linkages to care, especially in a pandemic. We did the study during a pandemic, and I really want to thank Duncan and Duncan's team and Gabriel and Alexander's team at the Rezo. We've also done studies in the past where we've tested women, rural Indian women, and we've also tested sex workers, STD clinic attendees, and injection drug users in Montreal, and found these solutions to be effective. How much time do I have? Okay, I'm just going to finish quickly. So machine learning and risk prediction models. So now the question is, when we had all these good technologies, do you want to go about and test everybody? So this is the question that bothered me, and that led to development of these risk prediction models. And we did that. We created a digital risk assessment tool with Zhang based on the data that we collected. It was a quasi-randomized trial that we completed with HIV self-testing, but we used this to develop a risk assessment tool to figure out who should be screened first. And we found that there were certain predictors, socioeconomic predictors that help you decide who should be screened. But again, these risk prediction models depend on the populations you're going to be developing them for. And we repeated this, the risk prediction for STIs in key populations from Canadian provinces. And we've done this, and this work is in press, and Fio is going to be presenting it. Fio is one of my students, and Cindy and Fio have done this work. So basically, I would encourage you to look at risk prediction models and see in your setting, when you're trying to apply these technologies, how is it that you're going to decide who should get multiplexing? Sometimes you have these best state-of-the-art cartridge-based, molecular testing solutions, but you're not aware of the prevalence. You go to a setting where you don't have documentation of prevalence, and sorry about that, and you don't know as to how you can, who you should be screening, and who you should be screening at the right time, and that leads to sort of confusion. But that's where risk prediction models will come in, and I hope that there will be more of an effort in that space. Machine learning, image recognition. So image recognition has also, we've used image recognition. WHO and FIND came up with a policy guidance on it. The the target product profile for rapid tests, and they're encouraging the use of apps and readers. And we've looked at it in our work also. And I think that machine learning, so the reason why I'm talking about all these things is if you combine all of them together, I think machine learning and multiplexing can work together. They can help you identify biomarkers. They can help you identify who's at risk. They can help you curate better diagnostic decision tools. They can help you curate clinical decision support solutions. You can monitor site performance if you deploy them with machine learning solutions. You can figure out which site is not performing really well, especially when you're implanting these different devices and platforms across settings. And now there is a move towards using multiplexed self-tests, and we've seen them being approved by the FDA for COVID, RSV, and that's a little separate from from the pathogens that we're talking about, but COVID, RSV, and what was the third one? Flu. And but now we can also think about how dual self-sampling strategies could be multiplexed, like chlamydia and gonorrhea. We already are using them for self-sampling with Cepheid solutions, or with Cepheid as in molecular platform-based solutions. You can use TrueNat, you can use Aniplex, you can use anything, but you need those portable ones so that you can use them in field settings. So that's where it's headed for self-sampling. So the third section is going to be, I'm going to go a little faster, about complications. Challenges, concerns, complexities, and how far can multiplex go. So multiplexed implementation, I hope I'm able to convince you that there are some intricacies in multiplexing, and that's where it becomes a little complex. So in the past, the flow-through devices really suffered from interpretation issues. And if you look at the data, sometimes interpretation of test results in low prevalence settings or low incidence settings gets to be an issue. And that is why I highly recommend that these devices upgrade and come up with readers that can eliminate subjectivity in field settings. Although you can also use apps, and we've done that in our labs. Connectivity is really important. So solutions that connect the results to the stakeholders, especially here I'm talking about the providers and the healthcare policymakers. Co-infections. In the past, avidity, the binding was impacted when there was too many pathogens that you wanted to screen. But now I think it's these solutions, these devices have become a little better. But again, if you want to bump up the sensitivity from 95 to closer to 97 to 98%, it's possible. So that's that. At the device level, there are interactions with inert materials that the manufacturers sometimes talk about, sometimes they don't, but that's important to know. So it's important to run these devices before you start your field trials. And at the patient level, sometimes, when you have co-infections, your immunity changes, your metabolic profile changes. So that really impacts sometimes the accuracy. It does not impact the molecular detection, but it does impact antigen antibody reaction. So those things have to be kept in mind. In terms of the positives, you get the results. You can devise test and treat strategies. You can create the shift to training, operations, and management. You can generate your workflows around it. You can create all these interfaces that can integrate the test results. But in terms of negatives, the cost of the cartridge is still high for global uptake. And that cost, I think we need a little bit of more action and advocacy around it. So where is multiplex complex? Sometimes at the patient level, patients are not really prepared. And as we've seen in our studies, I mean, we did find a few patients who were co-infected, and it's sort of a little hard to take the test results for, like HIV alone. So HIV, Hep C together is a bit much for the patient. So we need counselors to be present when that happens. Great counselor and great counseling training is important, not just around the counseling piece, but also around multiplexing. How do you incorporate that? And there are solutions. And physicians, communication is key. They need the turnaround time, but sometimes turnaround time, is okay. But at the end of the day, if you can get to the patient and get the test result and plan at the end of the day in one day, I think that is also appreciated by the patients. For health systems, I think when they implant these technologies, they need to look at workflow and processes. They need to map those out, look at what the change is going to be and how will people work around the change. How are providers going to incorporate that? In a recent study in Canada, in both Montreal and New Brunswick, we found that both the clinics, and both, one was a clinic and one was a community-based organization, both were able to work their workflows around it to be able to implement it successfully. So it's possible, it's not, and there are lots of other studies that have shown that it's possible to do that in camps as well. Now for NGS is going to be the cornerstone of modern genomics. So there are issues with high throughput sampling. Sometimes you get multiple samples, sometimes you're not able to interpret them in time. Sometimes you need like softwares, and sometimes interpretation is complicated. And sometimes you're talking about, so it's all about interpretation and how do you make sense of all of that data? And sometimes you need to identify the sequences to the right person. The complexity is also about, is related to sequencing bias. You can amplify different sequences and then you have to interpret them, and sometimes they may not represent what is happening in the real world. There are regulatory and compliance challenges. You have to adhere to the standards and to lab protocols, and you have to be careful about the complexity that comes with it and the error rates. So what is the future of multiplexing? So the future is very bright. We're talking about wearables that are can be implanted in every part of the body, and that will give you a lot of data. We're talking about quantum computing, which will be the overarching technology, which is a step up from cloud and fog computing, which can help you, which will be the underlying microprocessor underlying all of these technologies, which can provide you real-time data at a very efficient speed to transform your clinical plans. So quantum at the point of care will be a very powerful tool. And then there's the complexity with AI. So we are all concerned about it. There's going to be a huge amount of data everywhere. Canada is already investing in interoperability. There are a lot of countries investing in interoperability. So we should have one digital ID that allows us to have data that allows us to own our own health data. And we need to figure out the sharing laws around it. We need to figure out this blockchain technology that is available that allows you to protect the data. But again, costs around it, we need to bring down the costs so that we can keep our health data secure. There are cybersecurity compliance tools, and there are audits, there are frameworks, there's equity framework, there's a call. Equity framework is essential because we can't be, creating models from one population and applying it blindly to other populations. We need to generate data from all different subpopulations, especially from the underserved populations that people don't want to really do something about. And so equity frameworks are essential for that, to rule out the bias, because biased algorithms are huge now. We need to create environmentally safe products. I call upon industry to really generate like green products so that we don't have a lot of plastics around this. All of these technologies are using a lot of plastic, single-use plastic that can certainly be phased out. And there's the corporate social responsibility. So if they are making money from a country, they could use it to invest in in improving the lot of the equity-seeking populations in that country, especially the healthcare systems. Accessibility to digital solutions, well, there are laws, but people have to follow them. And so now I'm coming to the end of it. I hope I leave you enough time to ask questions. So hopefully you're convinced that the concept of multiplexing is very, it's challenging, it's complex, but it's been an evolution, and the entire platform and the technology and the field has actually matured now. They have evolved over time. Contexts of use have evolved. The technologies evolved. Accuracy is hugely improved, and impact evidence is evident. So with accuracy, early identification of infection, with work around the contextual part of implementation, which is informed clinical plans, improving pandemic response to find out who should be screened is also important, and screening for multiple conditions at what cost has to be thought through. So those plans have to be thought through before you think about implementing all these different technologies, because not just about the technology, it's about what you do with the technology that will make a change. So there is a huge need for investment case for countries to embrace multiplexing, lead to rapid integration and adoption. And if I may dare say, multiplexing is here to stay with quantum, with machine learning, AI, and digital solutions everywhere. So I was a big fan of Star Trek when I was growing up. Little did I know that I will live in the neighborhood where William Shatner comes from in Montreal. But here, Scotty used to say, beam me up, and he used, a tricorder. And I feel that this is where multiplexing is headed. The more portable it becomes, we would be able to sort of involve and incorporate the labs, the regular labs, as well as, like liver function tests, renal function tests, everything together with infectious disease profiles and panels. That's where it's probably headed. And I really want to thank, so this is the end of the talk. I hope you enjoyed it. I want to thank IUSTI for this opportunity, and Caroline for accommodating my request, Caroline and Greg. And I want to thank Mark Stibben for his gentle guidance. I also want to thank everybody in my lab members, and Juhi for helping me with this, and collaborators across the world, and my funding agencies, all of them who have supported my research program over the years. I want to share that I have a digital health course, I'm offering a digital health course, which is an online course, and I hope that you can, look it up. It's as part of McGill Summer Institutes, and it's going to be in June, and you will hear the latest from the latest and the smartest in the field. So multiplexing is going to introduce complexity, but with change comes a capacity and an appetite to change, and change is the only constant in life. So the secret of change is to focus all of your energy not on fighting the old, but on building the new. And I think we should believe in what Socrates said, and we should try and build systems that can embrace multiplexing. That's where. Thank you so much.
Thank you, Nikki. That was just an absolutely wonderful talk. And we have a couple of minutes for questions, maybe 2 questions. I'm sorry if we don't get to all of the questions that people have asked, but I'm going to go in order. So the first question is, how can health systems effectively integrate point of care STI diagnostics into existing syndromic management protocols without causing fragmentation of care?
So that's a complex question. I think the verticals, people managing the verticals have to come together and look at the economies of scale that they can achieve. So new business models have to be thought through, both in the public setting and in the private setting. So these technologies have a lot to offer, provided people come together to see how patient flows and workflows and processes, which is what I talked about, can be worked around it. So it's possible. It's just about coordination and integration and collaboration, and looking at what outcomes you want impacted at the end of the day.
Perfect. Okay, I'm going to take one more question. How can we ensure equitable access to point of care diagnostics for vulnerable populations, including adolescents, sex workers, and LGBTQ plus communities?
Absolutely. It's a great question. So I think corporate social responsibility, I would really think that companies that are making money off these technologies in countries should be called upon to give back to the society that they're making money from. That is the best way in which you can use corporate social responsibility to develop and embrace these technologies for the populations that are underserved. So that's a simpler solution, very simple to say, hard to implement. But if they embrace it, it is possible. And of course, I think that ministries and governments can make it harder or make it a condition of regulation. Like if we approve you, then you have to give a certain percentage of these kits for free so that we can use it for populations that don't get diagnosed in time. I mean, there are ways to do it. It just requires a little bit of creative thinking, I guess. That's
Perfect. Thank you so much. And I'm sorry, we're not going to have time to get to the other questions, but I would like to thank very much Nikki for giving this amazing presentation. Here is our next presentation, which is occurring on May 7th at 7 p.m. Eastern Time. There's a QR code for registration there. And I'd like to thank everybody for joining. Thank you so much.
Thank you. Thank you, everyone.